Hello dear friends, welcome to my channel. So far we have discussed about different topics in our previous sessions. So from this day we are going to discuss about each and every muscle and origin, insertion, nerve supply and action, and also we are going to discuss about the clinical correlations of that respected muscle. So today's class we are going to discuss about the first and foremost thing which we are going to explore see is origin of the deltoid muscle. So coming to the origin of the deltoid muscle, it is arising from three different areas. So it is divided into three different fibers. So anterior, lateral and the posterior. So the anterior fibers, they are called as clavicular fibers. So these clavicular fibers are rising from lateral one third of the clavicle, anterior border of lateral one third of the clavicle. Okay, so these fibers of which you are seeing on the screen, they are nothing but the anterior fibers of deltoid. Then the lateral fibers which are arising from lateral fibers of deltoid, they are arising from acromion process, lateral border of acromion process. So lateral border of acromion process, they have acromion tubercles. From the tubercles there are fibrous septa which are arising, fibrous septa which are attaching, and there are four fibrous septa which are attaching to each tubercle of the acromion process. They are descending down from that fibrous septa. These lateral fibers of deltoid, they are arising. So then from the below, so from the humerus, there are three fibrous septa which are extending upwards. These three fibrous septa which are fixing into between these four fibrous septa, and the muscle fibers which are arising from this acromion process, they are going to mingle with this three fibrous septa. That is why, so the lateral fibers of the deltoid, this is called as multipinnate. It comes under multipinnate muscle. So these are the fibers which are coming from lateral border of acromion process. And posterior fibers, they are called as spinal fibers, which are arising from the spine of the scapula. And these posterior fibers, lateral fibers and anterior fibers, three sets of fibers which are going to converge and forms a tendon. These are the spinal fibers. Then the three different fibers, clavicular, acromion and the spinal, they are going to descends down and converge and forms a tendon. At that tendon, it is going to get inserts to the deltoid tuberosity, which is present on the anterolateral surface of the shaft of humerus. Yes, coming to the actions of deltoid muscle. As I told you earlier, it is having three sets of fibers: anterior, lateral and posterior. The anterior fibers which are responsible for flexion of shoulder joint. So in the picture you can identify. So is a flexion, and this arm is moving back. So if it is moving back, the posterior fibers are acting. If it is moving forwards, that is flexion of the shoulder joint, it is caused by anterior fibers of the lateral fibers of deltoid. Let us see the lateral fibers of deltoid action is abduction of shoulder joint. Okay, so try to see here, lateral fibers are acting in this picture. Okay, so this blue color one, it is representing the acromion fibers or lateral fibers of deltoid. Let us see the posterior fibers. So the posterior fibers, which are called as spinal fibers, they are responsible for external rotation. Try to observe the picture. So it is moving outside. So that particular movement is called as external rotation of shoulder joint. So it is caused by the spinal fibers or posterior fibers. Now we'll discuss about the clinical correlations. Now moving to the clinical correlations. So as you all know that about the deltoid muscle origin insertion, the nerve supply is by axillary nerve. So axillary nerve, which is encircling the surgical neck of the humerus, and this deltoid muscle, it is a site for intramuscular injections. So how to give the intramuscular injections and where to give the intramuscular injections, that everywhere and every clinician must know about it. So the intramuscular injections are commonly given in the lower half of the deltoid, because of the upper half of the deltoid muscle Underneath this upper half of the deltoid muscle, we can identify the cervical neck, which is encircled by posterior circumflex humeral artery, which in turn is a branch of the third part of the axillary artery and the axillary nerve, which are encircling that. To avoid damage to that nerve and the vessel, we are preferring that lower half of the deltoid muscle for intramuscular injections. So in this picture, you can identify just below the acromion process, a 2-finger breadth just below that, and then from anteriorly you can see a triangular shaped area. Exactly the center of this triangular area is a preferable site for intramuscular injections. Then, as I told you earlier, the axillary nerve and the posterior circumflex humeral artery, which are encircling the surgical neck of the humerus. So, if you give the intramuscular injection to the upper half, you may damage this axillary nerve. That leads to the other complications. Let us see that. So this is axillary nerve and posterior circumflex humeral artery. Then what are the other clinical complications? So one is enthesitis. Enthesitis means inflammation at the sites where the tendons and ligaments are attached to the surface of the bone. So here you can see the inflammation around the shoulder joint. It is a common condition which we can identify if any person comes to the clinic with shoulder pain. So the first suspicion might be enthesitis, inflammation at the sites where the tendons and ligaments are attached to the surface of the bone. So that is one clinical condition. And here in this picture you can identify this lateral part of this. You can see the inflammation. Okay, so that is one condition. Next, calcific tendinitis. So what is this calcific tendinitis means? Calcium deposits build up in the muscles. Try to find out here. Calcium deposits build up in the muscles or tendons. So here under the acromion process above the humerus, you can identify some deposit over there. That might be the calcific tendinitis. So the calcium deposit may be present. So whenever the person comes to the clinic with the shoulder pain, first one is enthesitis, maybe enthesitis. Then we have to suggest him to go for the X-ray. If you find any deposit, it might be the calcium deposit. So the first suspicion. Then what are the other suspicions? Let us see that. Chronic avulsion fracture. So this chronic avulsion fracture you may see in the athletics. So the fractured bony part. So one particular piece of the bone, it may comes out and present in this particular area. So that type of fractures are called as chronic avulsion fractures. If it is chronic, it is a long time pain, that we may call it as chronic avulsion fracture. Then other condition might be myositis, that is chronic progressive inflammatory disease. So in the picture we can identify the piece of the bone which is present here. Okay, so that is called as avulsion fractures. So this is the second suspicion of shoulder pain. So next one is axillary neuropathies. So what is the axillary neuropathies? So damage of the axillary nerve causes deltoid dysfunction. So the dislocation of the shoulder or as fracture of the surgical neck of the humerus causes the damage of axillary nerve, causes the arresting of the abduction movement. Why? Because the axillary nerve which is supplying to the deltoid muscle is responsible for the two major movements. One is abduction, then flexion of the shoulder joint. So these are the clinical correlations of the deltoid muscle. Thanks for watching, dear friends. See you soon with a new class.